grief still further. All agreed that the importance of delivering a scanning facility was absolutely vital, not only for the discovery of causes of child loss, but to bring peace of mind to the devastated parents and wider family. In conclusion, it has become clear from this group that there is a unanimous level of support from Southampton's development of this facility. DWA would love to become involved in this project in any way moving forwards. It quite simply must happen to aid the healing process of bereaved families, in addition to preventing further deaths with the data gained by the use of scanning. It is clear the huge majority of bereaved families would elect for this option of the investigation of their child's death, and this can only help bring down the numbers of psychological impact and child mortality down. We wholeheartedly support this development and thank our ambassador for his involvement in the project. Selfless shout out for myself. So the next charity that I represent is the Stillbirth and Neonatal Death Society, and this is a statement from the Saving Babies' Lives team, which I believe some of the people in the room have worked with before in your projects at GOSH. And they state that SANS is a national charity with over 45 years that supported anyone affected by the death of a baby, funded and supported research, and focused on providing practice improvements to save babies' lives. Informed post-mortem consent has always been and remains a distressing decision for parents. We hear time and time again of the parents about the immense challenges of contemplating this choice amidst the trauma and grief, or simultaneously desperately wanting an answer to why their baby has died. Well, SANS was involved in the development of new HTA-endorsed post-mortem consent packages a decade ago. Many parents' experiences of the post-mortem process continue to be trying, not less as a result of the challenges raised by the ever-worsening shortage of perinatal pathologists, with some centres stretched to breaking points. Turnaround times of post-mortem reports have increased, leaving too many parents in limbo waiting for answers. This has an impact on the entire hospital review process, which cannot be reported back to the parents until the post-mortem report is ready. It is hardly surprising then that nationally only around 1 in 2 parents will consent to a post-mortem, a figure that has changed little in the last 2 decades. The inability for clinicians to identify a cause of a baby's death in the absence of a post-mortem may impact counselling and care of subsequent pregnancies, as well as impacting the long-term psychological harm for parents, who will still ask themselves in years to come why their baby has died. Alternative evidence-based approaches to perinatal postmortems can offer new ways to tackle service challenges. What's more, at SANS, we know that for many parents, less invasive autopsies present a less distressing prospect, making the decision to consent to a postmortem easier. Research from GOSH confirms the acceptability to parents of such choices of these less invasive procedures. But we know that less invasive postmortems are still limited to a few centres in the UK, and we welcome Southampton broaching this difficult but important subject, and we will work in addressing the current inequity of parents around choices for investigations to understand why their baby has died. That's some comments from the national charities, and I spoke to a couple of the parents I support locally within the Southampton area, and these are just for the interest of time, if some of the things that they came back with when I discussed this project with them. This is a statement from Lou, who said that before our son was cremated, I went to visit the funeral place he was at. I deeply wanted to see him. The kindest lady put him in a coffin and closed the lid as I wished to sit with him whilst I still could. But I did not know if I could face seeing him after the autopsy. I just could not bear not to see him and asked if I could. She then put him in a cold cot for me. I know it was my choice, but it still makes me deeply sad that he had cuts on him and to see him this way. I think if the autopsy can be avoided, even if people wish for answers, then they really should consider it, and I hope they do. This is another father called James who said, I do not remember being asked if I wanted one. I do not think I would have done it. I can't imagine doing that to my baby. Brewis comments, we would have accepted the scan with the expectation there may be no results. We didn't go down the autopsy path as I've seen autopsies, and no child should be put through that. And finally from Charlotte, my little girl had an autopsy and I was too scared to hold or change her afterwards because I couldn't face seeing the cuts. 4 years later, the regret is still a huge feature of my life, even with counselling. I do think choice on something so awful would be so much more humane. I'm not going to go into any detail, but there are publications and some of the authors are sat in the room and you'll know these papers far better than I. But it has been shown how non-invasive or imaging-based methods for autopsy alternatives make a huge difference in child loss communities. So I'd like to basically just hope that I've conveyed some of the weight and gravitas behind the parent experience behind the autopsies and the desire to see an alternative in this area. And welcome to take any questions if it's all possible, and I'll be here for the rest of the day if people want to talk to me afterwards.
Thank you, James. Does anybody have anything to say to James or anything to add? Do you have a feeling for what the feeling is nationally? That's a local snapshot. Are your organisations?
So the survey that was conducted with DWA was international, it was worldwide, because we have members across the globe, and that was feedback from them as well. SANS, as a national charity, has worked closely with GOSH to provide this, and they continue to do surveys around all aspects of childcare loss, and it's something that is wholeheartedly supported, and they want to see progressed further across the country.
Is there a feeling about how many centres would be needed if this were provided equitably across the country? So the Nationally Commissioned Service that we work in has 4 centres which provides coverage for the whole country. What would it be?
Yeah, so there was an RCR document done a little while ago looking at adult post-mortem imaging and how many centres you'd need to do that, and that was something like 30 across the UK. And a very small bit of that was then, and what about children? And they came up with a number of something like 5 or 6. So somewhere central in London, somewhere south, maybe somewhere then in the Bristol, kind of Cardiff sort of area, probably the big children's hospital, Birmingham, Manchester, somewhere up north, Sheffield, and then maybe Edinburgh, Newcastle, Leeds. So enough that you could get somewhere within 50 to 100 miles, that kind of area. But so yeah, 5 or 6, a handful of centres.
It does seem right that if it's done, it should be for everybody, and not just those geographically lucky to be in the right place.
Asked, could a baby be scanned locally and then the imaging sent to somebody to be reported? And whilst technologically that's very straightforward to do, what we found was that the centres who started doing things locally didn't follow most of the guidance and the protocols because they weren't used to doing those things. If you're doing things once every 6 months, don't tend to do them as well as someone to. So we took a pragmatic point, which was if you wanted to do it, send it to us and we'll do everything that's needed. Decentralise that. The more centres are able to do it, the less of a requirement that becomes.
Beth?
Yeah, just on that point. So I know that you said you've got 13, 14 trusts that you have contracts with. You get asked outside of those areas, and do you take them?
Yeah. If from where we can.
On a case-by-case basis, where we can fit them in, yes, we do.
You've got like a separate sort of area almost.
Yeah, it's sort of an exceptional. We would liaise with the centre directly and sort of on an exceptional basis.
So what consent is that family consent for? Your consent for?
Yes.
So it's families that have almost been given knowledge up front and go proactively after that, wherever they.
So the typical example is Muslim or Jewish families in Manchester or Birmingham, which is not available locally. Their religious or faith leaders know about this happening in London, and so they sometimes contact us. Their ways of contacting us are quite odd sometimes. You get approached by random emails and things, but it's about the pathologist who's on that week as to whether they have capacity and mortuary, fridge capacity and those things. They're the things that we consider, not where are they from.
And getting the word out about this technology doesn't worry you in terms of the massive potential influx of.
No, there's a balance here, isn't there, between doing the right thing for parents, but the NHS being able to provide the service actually. And if we and you don't try and develop this, no one will do it. But at some point, the floodgates, inverted commas, are going to open and you're going to ask for it, and they're not going to be able to have it. So they're not things that we can solve on a local level, but we can certainly feed into things like Royal College of Radiologists, NHS England, commissioning services to say, well, this is what we do. If you scale this up and train people, this is what we can provide.
I've met multiple times with Ruth, who's the CEO of the Miscarriage Association, and she readily accepts that we can't provide this for everyone at the moment, but she is wholeheartedly behind the project because we've got to start somewhere. You're never going to go from nothing to everything all at once, and it's got to be that gradual build-up, and that's why I think they certainly, and I'm sure SANS are so behind it, because we've got to start building up this ability to offer it to more parents and to give that choice over a wider area, not just 13 or 14 SLAs that come to us. This is something I think that could really hopefully go nationally.
Dave first, and then the rest.
And the political football term for that is a postcode lottery. people like the word postcode lottery because people immediately understand what it means. Where you live is different care. Actually, postcode lottery applies to lots of different aspects of healthcare. So, in a way, this is just another example of things that are not available to everybody equitably across the UK.
When you're looking at where we are looking to set up from the ground, how you know what your demand is going to be, because you could work for our nearest neighbours, which is about 3 or 4 hospitals, but then do we expect that actually we'll branch out?
Places Cardiff and Bristol and places like that, then you start seeing new cases for them not able to.
Started with your local fetal medicine unit and then expand from there, is my advice, I think.
Yeah, so following on from that, your 12 or 14 trusts that you work for, are they all sort of like your immediate neighbours, so North London, North Essex, Bedfordshire, Hertfordshire, or are they just random ones across the country?
Local, I suppose.
They are sort of
In that
yes. So
that
that's,
way.
yeah.
Salisbury.
They're places without paediatric pathologists.
Salisbury.
Okay.
Definitely be covered here.
Yes, yeah.
So I had a question for you, which was about how do we explain to parents in these situations who don't want an autopsy that we can do something alternative, and this is really the pushback from the pathology part of it, but it's not as good. It won't give you the answers. From the medical point of view, we want to do everything possible, and that involves an invasive autopsy and biopsy everything and look at everything. That's the comprehensive way, and that's how you will, leave no stone unturned. And I think that is appealing to some parents. How do you reconcile something is almost a step down? It won't be as good, but it doesn't involve some of the things you were against.
So it's very much a case-by-case basis, and everyone's going to have a different opinion. But predominantly, it's going to come down to what is the medical question asked. In my example, my daughter had bilateral renal agenesis. They saw that on the ultrasound. We just needed that confirmation, which would have been answered fine, and we would have been far more happier with a sub-gold standard imaging opposed to a full autopsy if it meant that our daughter was kept whole and not subjected to an autopsy. But that wasn't an option for us in this instance. So it's very much dependent on the person, and it's going to be very dependent on the medical question asked. But for those questions where it can be answered and save that child from being cut open, that's going to have a huge psychological impact on the parents.
Do you agree? Anything different about that?
The bereavement team, who we are, we tend to look after women from 20 weeks. So for the micro CT, it won't necessarily affect us so much because they would go to BAMSH or the gynae ward. But I would say probably half the women have said they don't want the invasive procedures, and I think they probably would go for something else because they want. I think they'd be happy with just something rather than absolutely nothing, and that's kind of where they go.
Dave.
So just going back to what I was saying just now about gold standard. If I understood what Kieran said first off, is that the vast majority of the problems can be picked up by the imaging, and therefore the histology almost adds minimal extra value for the vast majority. So it's not really the gold standard, it's total overkill, especially having to cut an up possibly to be able to do the full autopsy. And that's the way we want to sell the imaging.
Certainly it's an exhaustive process, so I think that's how much information do you need to get a confident underlying diagnosis, and that differs according to the clinical question. And there will be cases, in some cases, where a full autopsy, it will lead to important information, but it's for the majority of cases, a less invasive alternative can provide as much information with less distress.
It's a slightly different context as well. When you think about coronary pains, the function of that is to determine a cause of death. In a lot of these cases, that's probably already known or highly suspected, and you find in greater detail about that, or looking at the Crohn's risk and things like that. So,
and the coronial system is designed to be exhaustive. It's designed to say this is what we must do. We must follow this. So these parental consent intervals are different. I mean, the facetious analogy is if you go into A&E with a sore ankle, you don't get a whole body MRI. You get an ankle X-ray. If it doesn't show anything, you still don't get a whole body MRI. So it's a bit about what do we expect, what do we think we can do, and understanding what you'll miss using that technique, but then counselling appropriately.
I'll come back to you.
Well,
this is first.
I have a very quick comment actually on the importance of James's and Parent Association presence over here. I think, it goes without saying, but I think it's also worth mentioning that for us it's really, really important that we've got all this backing, and effectively this is the fuel pushing us forward. I mean, we have invested time in bringing the technology on site. We have it and we're doing fab research with that. But if we can actually deploy it to provide something to the local cohort, to the community, that's what's pushing us forward, and that's why James being around, it's really great for us.
I think, as you've often said, it's a moral imperative. The machine is there; it can do what you need it to do. Why are we not doing it?
I'm thinking about Renee actually, because she got to pick something that was picked up on her anomaly scan. And a sort of question for both of you two, sorry. My one thought was, when I was listening, was, are we, by limiting to 300 grams, if we do not have the ability here to do post-mortem MR certainly in the near future, are we then missing a lot of the patients we should? So at sort of that age, when they're fat, when something's identified on the anomaly scan, is there some wiggle room to go up to slightly higher, so slightly larger birth weight, and what is the implication of that? Because I'm just slightly concerned listening that actually a lot of the parents who would really choose this are going to miss out here. And talk about postcode lottery, well, it's a bit, gosh, you can have post-mortem MR, that's going to be a way of achieving that here. So sort of what sort of weight would you expect sort of of the baby who would have undergone termination as something found at the anomaly scan?
This year they've all been compassionate inductions. The people that we've looked after, and they've all been from some. We've had a couple of 15-weekers, but the majority have been between 20 and 24. And I would say the average weight of them is probably about 400 to 600 grams.
So we can iodinate body weight above 300, and we have scanned it, but it's just that it just takes longer. So we just had to draw something somewhere, and it's just about making sure that they are in sufficient solutions, so that the solution isn't the thing that limits the speed of the iodination, to make sure that it's the right concentration, which is what we've done on it. So you can go above 300, and we have up to 396, I think was our biggest, and we can go higher.
It takes 2 weeks to iodinate.
Yeah, maybe a bit longer, maybe 15, 16 days, but obviously the bigger it is, it's not straight, it then goes. So
I was talking to Stuart about this earlier, so if you've got an antenatal ultrasound, so you're of the gestation period of about 18 weeks, so spontaneous miscarriage with a normal antenatal ultrasound, the detection of any abnormality is quite low. So post-mortem ultrasound works very well just to confirm normality. I think the termination pregnancy population is different because they have recognised abnormalities often, and it's confirmation of abnormality. So if you're not able to do that with ultrasound, we do need something like that. But ultrasound is really useful. The gestation is really you have to wait for a while.
And the iodination and the technology we're looking at is what exists now, but you could comment perhaps on the future.
So with Microscopist hat on, I can definitely say that 300 gram is not the limit.
No.
I mean, on Monday we were scanning a zebra placenta that was that big, iodinated. But that doesn't mean that Microscopist is the most efficient technique to be used. So I think it will have the answer is to be taken under the framework of the clinical practice and all the considerations that dictate that. In terms of technology, there is no hard limit. You might need to extend the staining process, or scan for longer, or whatever, readapt your protocols, but that's all doable. Whether that's the best way of proceeding, that's a different discussion. And on top of that, you've got new technologies coming in. So we've already acquired a color detector downstairs, so Colorcity might be a way forward. Phase imaging is coming into view. So in a few years' time, you might end up with more weapons in your
Iodine is
At
one
your
of
disposal.
many contrast techniques you could
Yeah.
possibly use, and simple diffusion is just the easiest way of doing things with very small pieces at the moment. So pressurized diffusion might speed up the process. So I think there's lots of things. I think we're at the very beginning of saying, but what we've deliberately done is not try to experiment with some of those things. We've deliberately tried to say, here is an effective clinical service, because other people can now adopt the clinical service before we try and adapt it and speed it up and all the rest of it.
Now, if we find locally that the demand is for bigger patients, then obviously we'll come in contact with the guys, and then we'll develop a practice that's optimized for the cohort here. I don't think that there's a hard limit on what we can do, but we first need to have the service launched and see what the demand is, the local demand, and then adapt accordingly.
And we'll definitely lead you involved the whole way for that.
Well,
Thank
you know
you.
where I am.
Yes, thank you for sharing with us, James. So now we're going back to Owen again. Owen's going to talk us through the reporting procedure. Thank you very much for coming. Thank you so much. We'll keep in touch. Do you want me to direct you back to find a way?
Oh yeah, thanks very much for yesterday.
Nice one, mate. Nice.
I'll sit around for at least half an hour, but
Yeah.
thank you very much for
Pleasure. Thanks for dinner. Thanks for arranging it.
No, not at all.
See the activity part.
I hope so. Yeah.
Do it here and get your
And
people to.
I do hope that we take that forward on a research and an R&D basis as well. I think we've got quite a lot.
There we go. Okay, so we are descending or advancing, depending on your viewpoint, into the nitty-gritty of actually doing micro-CT. So this is split up into two parts. One is a very short lecture from me just about the things that I look at and how to try and report it, and then we're actually going to go through cases, more of a workshop where you can come and have a play and go through things and ask any questions that you want about what things look like. All right. So reporting is a subjective process whereby a radiologist looks at things and thinks, oh, I think that's all right, and that isn't, as we all know. But there are ways of trying to standardise that and getting a view into what different gestation age fetuses look like, and what the image quality should look like. And so we quite often use template reporting. I think this is one area where template reporting, particularly if you're new to it, is really useful. So standardised sorts of things. So how to report, we look at the quality of the imaging. The things you need to consider there are things about how well the fetus has been prepared, and that often means iodination. The image quality, where there's any artifacts, and then maceration will become a theme that will run through a lot of the things that we talk about. Maceration is the degradation of the fetus in utero in a warm water bath. So effectively, it's not autolysis, which is degradation of the tissue after death. It's a combination, effectively, of autolysis and intrauterine retention, effectively, and it gives specific abnormalities on imaging. Template reporting, so just really about being systematic, going through the brain, the chest, the abdomen, the limbs, so long as you don't miss anything. And then what we try and come up with really is an imaging diagnosis. So what does this series of images show? Normal, abnormal, what the abnormality might be. And then try and put that together then with the clinical context. So what gestation
what mode of delivery was there, what was the condition of the baby, is there any other imaging we've got, are there any other clinical details to give a likely overall diagnosis. So that's sort of my general approach. And in the back of your mind, as always, what are the types of causes of death you're looking for? What are the things that are coming up? So post-mortem imaging is not about sometimes tiny areas of micro gyral abnormalities in the brain, because that can look quite similar to maceration changes. Post-mortem imaging is about major diagnosis or major cause of death. That's really what a pathologist wants to write on their report. And then secondary things, if there are minor or incidental things. And that requires then a little bit of familiarity with post-mortem change. So the time since death, so the autolysis process occurs and certain things will change in the body, particularly fluid shifts. So if you're not familiar with the amount of fluid that moves around the body and accumulates in different areas post-mortem, these are examples from MRI, but there's quite a bit of teaching material out there to say these things where fluid accumulates around the heart, around the lungs, within the abdomen, around the body organs, within the soft tissue, are all normal physiological post-mortem change. Okay, so they're the normal things you expect everybody to do, literally to do after death. And these are time dependent. So if you have been deceased for 2 weeks and you're imaged, there will be more fluid shifts than if you've been imaged after 48 hours. We often get asked the question, how quickly do you need to image after death? And the answer is you don't need to image quickly, you just need to appreciate that things change with time. So I try and ask myself 4 questions when I see abnormalities or things I'm not sure about. I try and think, is this physiological? Could this be a normal part of the post-mortem process? Is it iatrogenic? Is it something we've done to the body or to the baby in preparing it or in its delivery or its mode of delivery or anything like that? Is it artifactual in terms of imaging? So is this something that the machine has thrown up or a combination of those things? And if it is, your SD card is full, not enough SD card space. And only once I'm happy that it's not a physiological change or an iatrogenic change or an artifactual, then I can call it a pathological. And particularly with post-mortem imaging, many of the things you would call pathological in life are not pathological post-mortem. So the best example of that is bowel dilatation. It happens in everybody. It's a common physiological thing. You start reporting it to the pathologists when you start reporting post-mortem imaging, and they say, just stop talking to me about that. It's not obstruction, they're normal bowel. They say, well, what about all the calcification in the bowel? And they go, yeah, that's also normal, that just happens. So in experience, knowing about things that happen after death is going to become a radiologist bugbear when they start to look at post-mortem imaging. Because you get worried about things you're missing. So you look at CT, things like this, and you think, oh my God, there's high density along the falx. That's going to be blood, that's going to be hemorrhage. You know, is that trauma? Does that mean something else? Actually, it doesn't. That's normal accumulation of blood in cerebral veins, and you get this thing called cerebral venous stasis, which is where blood stops moving, and it looks differently on CT. You get no grey-white matter differentiation. That's what hypoxic brains look like. If you saw that in a live child, you'd be reasonably worried because that shouldn't be what your brain looks like. But when they're dead, that is what your brain looks like. Okay. The lungs are filled with fluid. That's fine. That's also normal. Many of the babies you see, if you do fetal micro CT, none of them will have breathed. So you have to understand there's no gas in any of the lungs. That's a normal physiological finding. And then if the child has breathed and they're aerated, then you get post-mortem change in the dependent portions. So depending on how they've been lying on their front or on their back after they've died, that's where you'll see the fluid. So here in the bottom, there's a combination of fluid within the lungs, which is dependent change, and fluid around the lungs. And you see there as in terms of an effusion. So there's a little bit here with the fluid level here. Gas, we see lots of gas in funny areas in post-mortem. Gas accumulation in the heart and in the great vessels is very common. This is normal gas, so lots of your blood contains nitrogen. Nitrogen bubbles out of blood, and depending on that, again, how long you've been dead, there's more or less. Gas in the liver can occur for 2 reasons, either physiologically, because there's gas everywhere, or sometimes, in particular fetal life, ascending infection from the placenta. The first place it comes up is in the umbilicus, and then you get disseminated gas in the abdomen. So this degree of gas in the abdomen, without this degree of gas in the heart, is probably pathological, because it relates to ascending infection. That degree of gas in the liver with that degree of gas in the heart is probably physiological and gas coming out. So this is a slightly different interpretation of sort of things, and it's just really about experience. And then there's things that shouldn't be there. So the dark stuff here is blood in the pleural space. So there aren't any reasons why you should have blood in the pleural space. So there is blood and fluid around the lungs, and there is blood around the heart. So you look at that and you think, okay, so there's probably been trauma. So it probably has. So this could be termination of pregnancy. So termination of pregnancy is done with intracardiac potassium chloride. You have to go through the chest wall into the heart to inject potassium chloride. So there might be fluid in the heart, there might be gas bubbles in the heart because of doing that, and then you often get blood around the heart and blood on one side of the chest where things have gone through. So contextualizing the mode of death, or some of the information you have with some of the imaging appearances is quite useful. And the reason we know that, and the reason we can interpret that, is because we see a lot of these, and you can confirm quite a lot of this at autopsy. Then there are some iatrogenic things. There are funny things that we find. There's some odd thing on the CT, and there's some metallic artifact, and this is a left-right marker that somebody's left in. So there are things that happen that you don't always think about. So when we come specifically to micro-CT, maceration is a problem. So again, this process of the tissue effectively destroying itself over time, and some of that will occur in utero. So because that occurs in utero, and you're going to scan a couple of days after delivery, and then maybe the body's been in the fridge for a couple of days, you could be anywhere along this spectrum. So how do you interpret normal brain changes, or what normal anatomy looks like on a background of gradual change? That's really hard. And essentially, 0 is normal. Most people would be happy looking at that. 1 is just about okay. And you see that the maceration causes cracking throughout all the different areas, but there's still preserved anatomy in it. I think 2 and 3 are non-diagnostic, and that's fine. We have no problem with saying, look, this baby is so small, they've miscarried so long ago, we're happy to do a micro-CT, and all of the imaging is non-diagnostic. We can't help. That's fine. Yeah, there's no problem in doing that. Everybody always at presentation shows their nicest images, don't they? And they say, look at the brilliant stuff we can get out of micro-CT. So the image on the left, beautiful imaging of the heart, separate chambers. Yeah, you can see, so this is the left ventricle. You can see nicely even the valve. This is the esophagus. You see the rugal folds of the esophagus and the descending aorta next to it. You can see primary and secondary lobules within the lungs. I mean, this is the type of anatomy you would use to teach anatomy and embryology. But quite a lot of the time things don't look like that. So this is the effect of maceration, and you can start to see the body wall collapsing, again because we think you don't quite appreciate a lot of body rigidities. You have quite a lot of tissue rigidity in normal life, and that just effectively collapses when you die. So a lot of these are quite squashed in, collapsed, moved to one side, and it becomes quite challenging then to look at that. But you can still probably see normal ventricular appearances there in that heart. You struggle to see the great vessels maybe, and then this is even more maceration where you lose the tissue interfaces and things just become greyer. So it's an appreciation that if all of your images look like this, you've either got a specific population of macerated fetuses or you're not doing something right. The chances are actually a lot of them just look like this. So a lot of the miscarriage population are undiagnosed initially, may not know they've miscarried, they may not approach medical attention rapidly, then they might take a while to decide what they want to have done. So it might be 2 or 3 weeks before you receive the baby, and there's nothing you can do about those conditions. Other things to bear in mind is normal development. So we're going to see a range of fetuses between about 8 to 10 weeks all the way up to term. And one of the best examples of things that develop very rapidly during that is the brain. So primary sulcation, so where you see development of the Sylvian fissure, can occur quite early, 12, 13, 14 weeks, and then starts to develop a bit further. And then secondary sulcation of, you get all the other different bits in, but what we use this for really is to say whether or not the fetus looks gestational dependent, gestation appropriate. So a fetus of 24 weeks that has clearly not developed up to that point, but has a lot of maceration and things like that, then you think, okay, the baby probably just died 2 or 3 weeks ago. This isn't really a 24-week fetus. And here are examples of the kind of thing that you might get. So this is quite a well-developed brain. Not bad imaging, not bad maceration, not much cracking, so its quality is good. The patient's been prepared quite well. Quite a lot of soft tissue edema. Can you see around the skull? That's normal. That's to be expected. How are we going to evaluate the gestation of this baby? So there's no corpus callosum, but that's normal. So do you know when that develops? No. So somewhere between 18 and then 21 weeks. So by the time you're 22 weeks, everybody should have a corpus callosum. By the time you're 18 weeks, nobody has a corpus callosum. It's just the way in which it's developed. So a lot of the initial work we did on MR, around 20 weeks, people were guessing whether it was there or not, and they were no better than guesswork when the brain was extracted to look at it. So 20 weeks is really challenging. So the earlier the fetus, yet again, just recognising gestation appropriate changes within the brain. This brain is quite smooth. Starting to develop some gyrational folds, so if it has the Sylvian fissure and some of these gyrations, that's probably maybe 15, 16 weeks or so. So if this is a spontaneous miscarriage at 15 weeks, that's gestationally appropriate brain. People get slightly worried about the palate, the lips, the globes, and actually the eyes are something that we're not very good at imaging. That's mostly because the fluid levels in the eyes disappear, the lenses sublux and fall out. All of those are a normal physiological feature to the point where you can almost just disregard all of those abnormalities. You can look at the choanae and things in terms of palates and lip development, those sorts of things. And then normal development we've talked about in terms of the brain. The other area of normal development that you need to know about over fetal life is about bone development. Bones ossify in a different sequence. Ali Calder, one of my colleagues at Gosh, wrote a very nice article a couple of years ago in Paediatric Radiology about fetal radiography and how we can talk about normal ossification centres. And again, just becoming familiar. We start to get now some miscarriages and terminations very early on, so even 10 weeks, 11 weeks, where on a skeletal radiograph, there's almost no bone material. That's gestationally appropriate. So looking through different layers there, and so for example, your pelvis starts to develop iliac bone ossification around 11 weeks. You start to get vertebral body ossification, but not all, particularly not of the cervical spine, and not of the rest of them until maybe 16, 17 weeks. So you often get ossification in the middle, but then not towards the periphery. So a little bit of understanding of all the bits of embryology that you wished you paid attention to at medical school or whenever is really helpful. So these are examples of the kinds of things that we can do then with different imaging modalities. So this is bone development, and actually this is not uncommon experience. So termination of pregnancy for bowed femur. So short limb, bowed femur, but sometimes as a specific and isolated abnormality. So they're counselling parents as to the risk of skeletal dysplasia or unknown dysplasia, and so some parents opt for termination here. Do you know what this might be? Anybody tell? So this is a skeletal radiograph where they have bowed femur. If we magnify that up a bit, it's not just bowed, it's got additional bits around it, it's got a fusiform kind of aspect. So we do CT sometimes on some of these babies. Doesn't help. I think I said that in a previous talk. CT is not going to give you better resolution because this is a tiny fetus in a great big CT machine. Yeah, so you're not going to improve it. And then this is low resolution micro CT, and then high resolution micro CT. So does anybody know what that shows?
Is that the osteogenesis imperfection?
So these are healing fractures. So these are fractures, and that's what's caused the bowing. So fractures at both ends, maybe more than once. They've started to heal, which is what causes the periosteal extra bone. And then, yeah, that's what causes the bowing. So this is a subtype of osteogenesis imperfecta. Yeah. So we can help in those sort of things. And in fact, that's one I think that we printed out and that we showed to parents to say, you thought the thing was bowed, but actually this is what it was, and this was the fracture here, and this is the disease that we think your baby had.
So that's a case that staining is not necessary.
Yeah.
But micro-CT is still beneficial.
So micro-CT, that 30 minutes, no preparation necessary, the baby goes back, absolutely perfect. So again, horses for courses, specific abnormality, we think there's and you could take the femur out and image it in isolation. I think we did actually. I think this was a femur we took out rather than do anything, but we did the CT, whole. Yeah. And then hands and feet. Hands and feet can be quite difficult for pathologists to look at in detail because the babies are so small. Again, some of the development means that the hands are still fused all together, and the skin around everything means that you can't necessarily work out fingers and toes and things. So micro-CT and the volume rendering is really good at this because you can massively magnify in, rotate around in different ways, look at different segments, and then, if you're not sure how many fingers are in here, is there an extra bit here, then go into the cross-sectional anatomy to work out whether there's bones in it. One of the areas micro-CT is really good at is the heart, even when there's maceration, even when there's slumping and the body isn't quite right. So here you can see, this is the aortic valve. You can see, I'm not sure whether you can see 3 leaflets of it, and then this is the pulmonary trunk dividing into the right pulmonary artery, left pulmonary artery, and carrying on as the ductus arteriosus into the descending aorta. So that level of normal detail is readily achievable in almost all of our scans, except for the very, very macerated. So almost 90% of the time we can say something about the heart when the brain might be collapsed and those sort of things. So it's not always the case that sometimes maceration affects all body organs equally, and therefore the whole scan will be a waste of time. What is true about those very macerated fetuses is the pathology is a waste of time, as everything is liquefied and it's very difficult to get. So then getting into more detail, so you can see the aorta and the rest of the great vessels here. Normal rugal folds within the abdomen and the bowel. You're starting to see spine, again, no ossification in any of these vertebral bodies. That's normal. And then looking at the whole spine, you can see things like spinal bifida and any neural tube defects. And as we go through, so normal bowel, you have to appreciate what normal bowel looks like, and going out into the normal umbilicus, various things. So the adrenals in fetal life are almost as big as the kidneys, and can be sometimes difficult to distinguish from each other. The adrenals also sometimes look quite cystic in very early fetuses, as do the kidneys, but they're not, it's just normal appearances. We did a quick paper about incidental calcification. Lots of people report lots of bits of white stuff in the abdomen on fetal x-rays, and actually this is all normal within the lumen. So early meconium in fetal life calcifies quite often, has no significance. Pathologists really don't like you telling them about this because they're not going to go through the whole of the bowel to find bits of calcified fecal matter, effectively. And then, yes, so these are the kind of examples that we will try and go through. So normal ossification, can you see in the shaft of the humerus, and then cartilaginous aspects of then the glenoid and those sort of things. Normal lobation of the lungs, so normal horizontal and oblique fissures, those sort of things. Normal fluid around the lungs, and then the normal liver here, normal adrenals. You can see different layers of adrenals. We know there are the medulla and the cortex. Normal kidneys, normal spine, bit of ossification now at this gestation. Can you see this is an older fetus with more gestation and more ossification centres now developing all the way down to the sacrum. And we talk about pelvic development. Now, external internal genitalia. People would think this is something everybody wants to know from fetuses at early gestation. We've done quite a lot of work with John Ackerman, who's a professor of endocrinology. He sees all the intersex children and those with ambiguous genitalia and those with congenital disorders of sexual differentiation. It's actually really hard to tell sometimes what a small penis or an underdeveloped penis and scrotum is versus an enlarged clitoris. So the best way to deal with this is not to comment on gender. The internal gonads look the same, whether you're male or female. The presence of a uterus helps, but the external genitalia look the same at the types of gestation that you're going to be looking at, 14, 15 weeks. So the safest thing to do here is not to comment on gender assignment. And then again, more good examples of really detailed imaging. You can do some quite nice reconstructions of the heart, recognising different chambers. So the right ventricle and the left ventricle do look different. They are effectively normal configuration by about 16 to 18 weeks. There's a normal patent foramen ovale in all babies in fetal life because they don't have a proper pulmonary circulation, and then even the pulmonary veins you can track back. So you can give quite a detailed cardiac anatomy report on micro-CT even at early gestation. Again, so you see these kidneys are slightly better developed, a bit more normal in terms of the tubules and things, a little bit further along. The pancreas here looks a little bit cystic and just normal pancreatic development. Lots of rubal folds in the gut. Very rarely do we find congenital gut abnormalities in the sense of where they are in terms of in the body. Very rarely do we detect bowel obstruction, but the more likely things you're going to see are things like exomphalos loss and gastroschisis and those associations. So some examples of some of the published things that we did. So this is a fetus, lots of fluid around the heart, around the lungs, normal physiological change, and this is just to show normal aorta and a normal pulmonary trunk in a baby of about 11 weeks that we managed to get some quite good imaging on. This again, this is not rocket science. This is a big congenital diaphragmatic hernia, so with small bowel loops, everything up into the chest. So at the level of the heart, you've got a heart, you've got a squashed right lung, you've then got the liver up into the chest, bit of the stomach, and then lots of loops of small bowel. So paediatric radiologists are well used to looking at this, and they'll just say, oh yeah, I can find congenital diaphragmatic hernia. In fetal life, the reason that's important is not just the hernia, but of course you've compressed the other lung. So it's how small the other lung is that will determine what survival characteristics would have been like. And then little things that if you don't look closely enough, you'll miss. So we missed things like a subtle, very small neural tube defect on micro-CT because the baby otherwise was quite normal. In fact, it's quite obvious on external examination. So this isn't something to use in isolation. This is something, you know, everyone can do an external examination. What's interesting is, so we tend not to. We tend to prepare the babies, wrap them for scanning and send them back. So actually quite a lot of the external abnormalities we're independent of, or not really paying attention to, depending on how you want to term that. So we miss some of those things. And then really major abnormalities again. Is this ventricular megaly, or is this on the holoprosencephaly spectrum where actually there is a single ventricle that's developed, and this is a neurological abnormality. Again, this is the optic nerves too close together. So this is a lobar holoprosencephaly, which they had diagnosed as ventricular megaly antenatally. And so this just goes to show, of course. Can you see this is forceps, tiny forceps trying to pick up a tiny brain and then dissect this? So the pathology aspect of fetal brains is really challenging. So to be able to say, no, actually on the micro-CT it shows a single ventricle, we think this is holoprosencephaly, gives them a huge steer, probably because there are some genetics related to that, and they could, even if the brain disintegrates when they remove it, there is some genetic components that they could do something with. And then sometimes you call funny things, you see funny things in the neck, little cystic abnormalities. Could that be something? Quite a lot of cystic hygromas and the lymphatic malformations we see around the neck go down with the fluid shifts that occur after death. So actually there are babies who have been born with massive cystic hygromas, and when we micro-CT them, they look normal. Quite a lot of ventricular megaly goes down after death. So that's really challenging because that's a physiological process that started with an abnormality that then becomes normal. So we recognise that happens with post-mortem MR and those sort of things. So it's just something you need to be aware of. So if they say massive ventricular megaly, you do the micro-CT and it's normal, doesn't mean there wasn't ventricular megaly and those things. So there are some specific examples. Okay, that was all I wanted to go through in terms of slides. We were going to try and show you now some things on the network. So let me just see if I can take this. That's right. Take that back. Give us a second just to switch things over. Make sure I do this correctly. Go across here and in here.
Can you help?
Okay. Yeah, I think so.
Can I ask a couple of questions?
Yeah, of course. Yeah. Sorry, we'll pause. Yeah.
So, two things. One is, can you perfuse stay or die and do an angiogram on fetuses that small?
Yes.
One, post-mortem. And B, you mentioned about not very often.
So let me answer that question first, because we haven't done very much. We did some work with microfilm and mainly for placentas, So we want to differentiate the mother and fetal aspect. It's quite fiddly dealing with microfill, as you know. We've never tried to do it in a fetus, so I don't know the answer to that. I suspect it would work quite well, but actually iodine works quite well just to differentiate all the vascular compartments. So there isn't, for me, a need to fill the vascular compartment with something to differentiate it from everything else. So that's the first thing. There is a group in France who've done quite a lot of angiography using CT, only on babies down to about 18, 20 weeks or so. So there are papers on fetal angiography, post-mortem CT. Again, my experience is it's quite fiddly, and there's usually a better way of looking at it than going through that process. That's personal experience.
Okay.
Your second question?
Yes. Is there any benefit in utilizing volumetric rendering? You mentioned that often you are not sort of focusing on external examination. However, you do have the data to have a virtual external examination, and you also have the data to selectively select the heart and have an external 3D examination of that organ or the other organ. Is there any real-life benefit in doing that? Of course, taking into consideration that takes time, post-processing, and everything that comes along with segmentation of challenging volume data.
So I'm a bit biased because radiologists like looking at actual data, and then they stop. They sometimes do coronal sagittal reformats and things, but then they stop. So we don't see sometimes there's much benefit to making fancy pictures of something that we already know is there or can demonstrate in other ways. That doesn't mean to say there isn't an advantage. And people have done this throughout, in living children, 3D volumetric analysis of bones, for example, fractures or orthopedic things. Sometimes there's a small incremental advantage. I haven't found there to be much advantage in these, but I'm happy for people to experiment with it and do things. Again, what I think we're very much dealing with is trying to be the most efficient way of imaging, and then to try and find a minimum data set to provide a good report for as many patients as we can, rather than the secondary aspects of research in terms of how can we explore this data further, and what do parents want to see, would there be an advantage in those things. Do you guys agree with that? Do you do a lot of volume rendering? For the heart, it's useful, I think, for complex abnormalities.
I can't actually do the heart. We would do it for the bone things, for the orthopedic work, but we're doing it less for us and more for the orthopedic.
So it's illustrative almost, but your original diagnosis is done on conventional imaging. And that, I think that's a slightly traditional radiologist approach rather than the best way. But
So, for example, the external defect that you mentioned earlier, most probably you would have picked up by a volume rendering of the specimen. I was wondering whether a similar
that's right. Well, this is what we
gain
see. So we have the whole fetus.
Could
so
be had.
Axial, coronal, and sagittal sections through here. So we effectively got everything that we need to be able to do that, but then we can also spin round and then
might be a bit laggy.
Just turn one of the lights off.
Yeah, I'm just trying to get the right. No, you can't zoom on that. Is it the other?
Yeah, there were.
It typically is a zoom function.
There was being a bit funny the other day. You might want to use.
That's right. Let's do this instead. Oh. Let's make this whole. Yeah. So this is effectively the kind of data set that we would normally have. So this is a whole body, all the way up, for the brain. So rather than me take you through it, why don't people just contribute and just tell me what they think they're seeing? Because the easiest way to do this is just to say, well, I think this is this normal, is this abnormal? Who knows? So the first thing you notice maybe is that it's not quite straight, but do you notice any sulcation? Is there anything in the brain to tell you what gestation this baby might be? So just looking at the surface of the brain, effectively. Oh.
Going back to that diagram you showed before, not very much. So somewhere in the early part of that set you showed before of development.
So this is going to, okay, you're going to have to bear with the lag here as we go.
Keep going up, Owen, I think.
So I'm minus 1300 now.
Yeah, keep going, keep going, keep going.
Yeah. It will come out. Which one? This one. Ah.
That will be on the center slide. So then I think you can. And avoid having your mouse going off the screen because that's where it jumps. So stop it there and then restart if you have to.
Tell me that now.
And there might be a couple of seconds lag between rendering and at full quality.
Okay, so there's very little sulcation here. So this is going to be quite early, 15 weeks, 14 maybe, something like that. Yeah.
What's the bright spot in the middle?
Yeah, what is the bright spot in the middle?
Blood?
Pardon?
Blood?
So accumulation of iodine, preferentially in blood vessels. So can you see the bottom bit?
Yeah.
Yeah. So the major blood vessels in and around the brain, and then you start to notice the iodine and other things. So they're surface vessels. Yeah. So iodine is preferably taken up, I think, by hemoglobin, which is why you see it in a lot of these areas. So yeah.
Okay, so on the top of that, where it was very strong back there, is that ossification or is that iodine in blood vessels?
No, it's iodine. So there's iodine layering there on the surface and stuff. So that might just be dependent. And, So that's almost it's almost we've created that layer by putting them in iodine. It's a bit iatrogenic. Okay. Any other comments about the brain? Is there anything major we need to think about here? What are these things in the middle here? So the ventricles look quite dilated if you're not used to looking at that. Yeah, it's probably normal for this gestation. Here we've got the germinal matrix, which again is normal for this gestation. So you start to appreciate some normal neuroanatomy, and the thalamus, and then the brainstem. Fall off again. Okay, so the way I need to do this is to do. Sorry about this. We're dialing in remotely to data sets that are sitting on your computer downstairs, aren't we?
Indeed, yes.
Okay, so the globes, I'm just going to hold on to this. So the globes, can you see, are decompressed. They collapsed, the lens has gone down. Yeah, there's gas in the airway, so that's normal because both mouths are open and noses are open, so that's okay. The tongue is there as normal, and then you start to see go down to the brainstem, and then you start to look down towards the neck. So there's no abnormality there. What can we see here? Okay, the larynx. You see the larynx there in the middle. Yeah, so these are normal changes as you go down from the oropharynx, down into the larynx, the vocal cords, and down. That's going to become the trachea with the esophagus behind. I'm going to start to
avoid going off the screen.
Yeah, we're going to avoid going off the screen. So we're going to.
You can use the mouse wheel as well. It should render.
Oh yeah, okay, that's better. Okay, this structure anteriorly.
Sternum.
So the sternum is here, so the sternum is unossified, so the sternum will look grey. So this is a little bit of a rib coming around here. These are the scapulae and then the humeral heads. So you see they're grey, so there's no ossification within those. So this thing that's taken up iodine just inside the chest is the thymus, with the main brachiocephalic vein and things like that running behind it. Okay, so the hands and things are often going to be outside. So a little bit of fluid around the lungs. Can you see that? Mm-hmm. Yeah, that's normal. So that's fine. And then you're going to come down here. So major cardiac vessels are now coming in. So pulmonary trunk. Yeah, so brightness. The brightness in the vessels is all normal. So pulmonary trunk here, splitting into the right and the left. Normal anatomy means that there's a ductus arteriosus that communicates. So that's there. It's a little bit collapsed in this patient, that's all fine. This is the aorta. They should be roughly similar dimensions, this kind of gestation. And then this pulmonary trunk comes off the right ventricle, the aorta comes horizontally off the left ventricle. You've got normal lobation here of the lungs. You see those horizontal fissures. So this is all normal anatomy so far. The esophagus is normal, the ventricles are normal, looking at everything that's there. And then as we go down into the abdomen, so the liver is remarkably large in fetal life, takes over almost the entirety of the upper abdomen, bar stomach, and look how small the spleen is in comparison.
And that's normal.
That's normal, it's normal anatomy. And then everybody thinks these two things either side are going to be kidneys. which they're not. They're adrenals. The adrenals are massive. In fetal life, you can see that they're adrenals. They have several layers in them, so the different cells that you have in the adrenals. This is the pancreas, just going across there. And then this liver is not very macerated at all. So there's a little bit here, because you can see the greyness is a bit more homogeneous than really splitting out. So I think the contrast scale we've got here with the iodine is not quite amazing, but it's not that macerated.
Is the brightness or the top anterior surface of the liver, is that iodine related, or is that just image artifact acquisition?
So that's a combination of both. Okay. So there's partly iodine related, but if you do MR of livers, you also see this rim of slightly odd high density or low T2 signal around the edge of the liver. So there's something about the liver, which means even within the liver, I think the enzymes and things settle a little bit somehow, and we thought it was artifact when we started. So if you take these livers out and look at if there's anything different around the outside than on the inside, there's nothing. It looks exactly like on the liver.
One thing.
These are the low resolution images, so this is the whole body.
Yeah, okay.
These are the low res images.
One thing is worth.
Didn't need to do that.
It's further down.
To the left.
One thing that's worth mentioning is that on organs that you have quite a lot of iodine uptake, you might, depending on the energy you're scanning, you might or might not notice beam hardening effects and gradient slopes on top of slopes coming in from staining procedures. Right? It might be that because there are several copies of them.
Okay, so here's the same baby in high resolution. Let's look the other way. There's right, left, flip. But can you see? Okay. Just to see if we can recreate that line. And it's much less distinct on this. Okay? So I think it's partly iodine, it's just related there, and partly artifact. So we do a low resolution scan firstly, just to see whether, make sure the baby's iodinated and ready to scan. We do a separate head and body, as you heard from Ian already. So this is high resolution, and you can see the difference in resolution. And actually, you can start to differentiate a few things. So the layers in the adrenal, for example, much better here. And then I was just going to take you down through normal bowel, ossification within the limbs. You see that? Mm-hmm. Yeah, and then cartilaginous ends of the radius and the ulna, cartilaginous hands with a little bit of ossification in the metacarpals there. And this is all normal anatomy. Okay, let's see if we can show you something different. So what do I need to go on? Do I need to close?
You try to open the next data set.
Yes.
So close those down, I think, to make it.
Do we need to? Yeah. Do we need to do them? Okay. Did anybody want to have any questions, or anybody want to see anything? Anything's gone past that they're not sure of? Yeah.
I've just got a couple of questions. It's really about the macerated babies.
Yeah.
So first of all, do they? If you have, well, I suppose I want to understand the extent of how maceration limits the post-mortem. You showed us a lot of data in the beginning. So in terms of those severely macerated babies that were non-diagnostic, when they they went on to do a PM, full PM, were they also non-diagnostic with no additional information?
Yeah. So the most likely reason that a PM is going to be non-diagnostic is because the tissue is disintegrating effectively. And so that's typically severe maceration where there's been a long interval between the death and receiving the baby. Yeah.
So that brings me on to, can you roughly date the maceration changes? You know, on histology, we can have a look and you think, well, okay, it's dead, I don't know, roughly, it's all very rough, isn't it? It's not precise.
Yeah. It's so rough, it's probably not worth doing it, is how rough it is. So, because if you received the body on the day that it was delivered and you saw maceration changes, yes, you could estimate then back as to how long the baby would be dead. The best way probably to estimate the baby's gestation is probably things like femoral lengths and tibial lengths, which we can do from skeletal radiographs. That's going to be as reliable as anything else we do. Given that we don't receive the baby on the day of delivery, and it could be 10 days or so, you've got to factor in the 10 days post-mortem before scanning, plus the however long might have happened. So when you see severe maceration, it might have taken 3 or 4 weeks to develop that, but trying to date, that probably isn't very useful. So,
well, apart from if you were trying to work out sort of fetal placental mismatch or issues like that, isn't it?
yes. So the mother reporting a loss of fetal movement is probably going to be as good an indicator of when that happened.
And then the other question I was going to ask, you mentioned HIE changes not being very, not regularly picked up. So does that mean that when you have a clinical history of HIE, you're sort of not going down the radiology path at all?
No, what it means is every death is a hypoxic ischemic event. So when you see hypoxic ischemic changes on post-mortem imaging, trying to differentiate which of those are because of physiological death and which of those might have happened during life to give a hypoxic event is almost impossible using conventional imaging like we do.
But for those, histology would help, roughly,
yes.
Isn't it? So that's the question I was asking. So if you've got HIE and that's a key issue, then you're sort of not going down the
so, HIE tends to be a recognised clinical phenomenon now rather than something we would diagnose on imaging. Like I say, the brain will look the same whether you had an antenatal, an antemortem event or post-mortem change. Okay, thank you, Ian. Sorry, my beautiful assistant has brought up, which I will now proceed to destroy. Okay. So this is a good example of maceration.
I just brought up the torso.
Yeah, that's fine. But even the brainstem, can you see how all of this tissue is effectively just fragmented to the point where it's non-diagnostic? Yeah. This is an older fetus, and you see ossification already in the neck. Yeah.
Can you just orientate?
Okay. So this is So the head is here facing this way.
Yeah.
And this is vertebrae or the brain, the base of the brain. These are then vertebrae going down, and we can go down then to steps of that. It can be really hard to orientate yourself
So
because the fetus can be
the cone being there.
Yeah.
So that's it.
You see it
so
now.
rotation was like
Yeah, the shapes that I was right on in the first one that I'm familiar with are not there.
Yeah. As we go down to the torso, it will start to become a bit more apparent. It's just
So you can start to see here. So this is scapula. These are ossification now within the vertebral bodies and the posterior elements, and then this is starting to become now axial segments through the chest. Let me just go back to that.
Practically, when you're reporting that, do you reformat MPR it in multiple different planes and try and make everything look straighter, or do you just report off the axis?
So that's what I did before.
Sometimes you can't.
I set it all up so that it's a bit like we used to put films up for you in a way, so that we always have the whole body orientated in an anatomical position. But that sometimes is difficult, like this one, where the head's maybe up to the side, but the body's twisted as well. Then we'll have the head, so that's anatomically positioned, and then we'll have the body anatomically positioned.
Yeah.
But it automatically will create a coronal and sagittal in the four windows. So you see. Yes.
So can you see the orientation of the body here on the 3Ds? I mean, it doesn't matter how you look at this body, it's going to be really hard to try and look at it in a true axial or even a true coronal, true sagittal. So you almost just have to work with what you've got.
And this is because the baby was brought to us like that. It's in that difficult position already. It's not as a part of any of the iodination process because it's more like this miscarriage.
No, that's fine.
It's just become more maculated, and so it's the shape and it's just very different. But that's the challenge. But that's almost the beauty as well of this software or software like it. That you don't have to create those MPRs and wait for a while because then create another one. It will automatically do that for you live in a way as a lash because of the way we're doing it today. But it's effortless. It just happens automatically.
So can you see the heart is massively over to one side? All of the stuff in front is ribs. All of those are ossified ribs. So trying to work out here whether this heart is normal is very hard because there's had a lot of slumping over of the body, so your normal anatomical references are off. I'm just trying to see if I can show you. Let's go up through. Can we see the great vessels at all? Only just about. Yeah. So that's quite challenging to say anything about the heart here. So actually the internal structures are not too bad. The internal grey, the differentiation is not too bad. This is a very macerated liver. And you see with cracking effects effectively through it. But the adrenals are in the normal place. The kidneys are in the normal place, albeit, and then there's a lot of bowel here that's out, and this almost looks like an exomphalos or a gastroschisis with lots of bowel outside the patient. So you might call that a pelvic kidney, but actually it's just where it is relative to all of the other abdominal contents. And then sometimes with severe maceration, the anterior abdominal wall sloughs open. So what you then get is you get or spillage of all of the abdominal contents. If you see that in a severely macerated fetus, it's likely to be maceration related or delivery related rather than anything else again. So these are iatrogenic or physiological changes or artifactual from maceration before you can start calling them pathological. Okay, that's for really for that one.
Would there be any way in which the mortuary could help with limiting those slumping effects, like the way they position a
yes, but usually by then it's too late.
Yeah.
By the time you receive the body like this, there's very little you can do, and I think if you try and manipulate the body to make it nice for imaging, you'll probably start breaking things and doing things.
No, gets it 5 days before you. You've got then 5 days of that they might be able to at least slow by positioning or supporting around or something.
From my experience with babygrams, it is really quite crucial how the local mortuary, and I know Tanya Foetal did quite a lot of work a few years ago, because we used to just get them sort of in sort of whatever position that they could do in the pot, which is really it's not very dignity. It's not very good dignity, but secondly, actually, then even trying to get the AP and lateral babygrams, because to get a really good AP and lateral babygram, we need them so they now have their head cradles as well to protect them so that they don't the head isn't accidentally flattened. So generally, unless that they have died and been dead in utero, they do come in as good a condition as they possibly can. Because when we first took over, we saw quite a lot of difficulties getting decent AP and lateral babygrams just because of what they came to us. So let's say the APTs downstairs loads of work on getting them to UHS, because the ones we got from PAH were great, were as good as possible, but the ones that were coming externally were a challenge. And now they come, but there's a lot of work on how they get transported to UHS and how they're cared for when they are delivered to the midwife teams.
They're going to be putting iodine with formalin, that will actually be even more relevant, because then they will have to be positioned appropriately even before they go into the iodine solution, because they're fixed in formalin and you can't manipulate them easily.
So some of the imaging you're seeing is the best you can get on that particular fetus. I think, sometimes in utero death and so a miscarriage, actually that is the condition that the baby's in when they're delivered. There's nothing anybody can do about that. But it's all about education and communication, isn't it, by the time you get to that stage? Where are your major referral centres going to be? Which hospitals do you have to talk to get that kind of messages out? Yeah, those kind of areas need to know a little bit more about how you want things prepared to try and do that. Again,
they come quite nice AP position.
So you know what you're going to get. This one. This was less than this is the card. Perfect. Okay.
And then learning off
Okay, so anybody want to hazard a guess and talk through what's going on here? So some normal structures, normal thymus, normal trachea, normal esophagus, normal vertebral bodies, normal spinal canal. You see the musculature quite well. There's a little bit of ossification in the ribs and things here as we come down. So normal apices of the lungs. There's a bit of midline shift. You see stuff is pushed over a little bit in the centre here. Yeah. And what's that? What's this here?
Liver.
Yeah,
Right, liver.
this is the liver. Can you see a little bit on here? The liver actually goes across, absolutely. So, but hasn't completely compressed that left lung. So this is a relatively small congenital diaphragmatic hernia, mainly containing liver. It looks quite big there, but actually the development of that lung means that it has either happened quite late or has been relatively small. Okay. So then the questions with congenital diaphragmatic hernias, they go in a bit of small bowel into it. So the stomach is normal, it goes across here, a little bit of small bowel goes there, and then that's the normal diaphragm on the other side, and then that's your liver. So one side and the other side is flipped up into the chest with a diaphragmatic hernia. Okay. So then the question becomes, is the heart normal? So here you've got a pulmonary trunk and an aorta next to each other. They look relatively similar size. If we go up, the pulmonary trunk divides appropriately. Can you see that? And then continues up as the ductus arteriosus into that aorta. And then the aorta becomes a descending aorta, so that's fine. There's the arch of the aorta, just there. Can you see that going across? So do shout if you're not able to see anything. And then the aorta itself goes down into there's the aortic valve next to the pulmonary valve, goes down into the left ventricle. So actually the cardiac anatomy, gross anatomy here, is normal without going through all the veins and things like that. Yeah? So normal cardiac anatomy, smallish congenital diaphragmatic hernia. This baby would have done reasonably well because of the left lung development. You can see the lobation is normal and the lobulation within that is normal as well. So this baby would have done okay. And then just to check within the abdomen, go through the liver, not that macerated, quite nice, quite clean. But is there a reason to do an autopsy in this baby now? Probably not. So normal adrenals, just check they have normal kidneys on both sides. Yeah, and then we use things like sagittals to look at normal. Just check that they don't have any neural tube defects. That all looks fine. Cord ends normally. So through the process of going through systematically, actually this baby is normal apart from the congenital diaphragmatic hernia.
Is that slumping? Is that at the bottom where you've got that bright? Is that just blood pooling?
Yes, the very bottom of the skin. Yeah.
Yeah, you've got some air spaces in there as well.
Yeah. So you start to notice a lot of things on imaging, but you have to try and revert back to what you're trying to do is talk about major clinical diagnoses. Yeah.
Can I ask, you mentioned earlier about GI abnormalities.
Yeah.
Not many. Things like intestinal atresia, how easy is it for you to pick up, or is it that you're not seeing it because the abnormalities are not there, or there's an issue with the scan and the resolution picking up? Because if the fetuses, you're not going to have that sort of typical obstructive.
Yes, that's more the problem.
Yeah.
The things decompress, and so you don't get the upstream dilatation, and so there could be lots of abnormalities there or not.
Is something where the pathways are.
So in that sense, we're doing the same as autopsy, because we're seeing the same things on imaging that you would see if you opened up. I mean, how do you detect obstruction if you gut obstruction and atresias if you don't have antenatal indications of it?
Yeah, I mean, our standard approach is to remove the bowel from the rectum and basically work backwards and then just check.
Yeah. And do you do that routinely in everyone that you do?
Yes.
Yeah. Okay. That's fine. Yeah. So we've got the imaging corollary, effectively, of normal bowel. That's not to say that there isn't an abnormality within it. Okay, so that is that one. Let me just show you.
So a question from online is, could the remote site do the fixing, then send to you, and then you do the iodine staining as a separate stage to try to reduce the maceration?
That's an interesting question. How long would it need fixing for?
Yeah, probably
a day?
3 days.
3 days. And then iodination afterwards.
Theoretically, yes.
Yeah.
But we haven't actually tried that.
It would take longer, so it would lead to, wouldn't it? Because you'd have to go through 2 processes rather than 1, and we do it in 1 to try and reduce the time. Yeah, theoretically, I don't see why not.
Maybe as soon as you receive it, you swap it into the half and half fix and stain, and you still start as soon as you get it.
Yeah, I mean, we've iodinated fixed tissues from surgical specimens, and
yeah,
iodinate.
You can iodinate, absolutely.
And we've iodinated historical ones before.
Yeah.
If the referring hospital did it, then who would have done an external examination?
That is so you will obviously be missing the external examination, but because examining a fixed fetus is not the same as examining a fresh fetus.
And triaging so that we can, as Kieran says, you can go on and do the further pathology examination, the internal examination.
Okay, so maybe there are practical reasons why you wouldn't want to do that rather than theoretical reasons why you couldn't. That's what it sounds like.
Yeah. Possible but not ideal.
Possible but not ideal. Yeah. Okay. Fine. Let me show you this. Is that the same one? Yes. Okay. All right. So let's look at the heart in this baby. So can you see the pulmonary trunk in the middle? So this is the aorta. The aorta's collapsed here. This is the pulmonary trunk coming out and dividing into 2. And then as we go down into the heart, so the pulmonary trunk goes into the anterior right ventricle, which is quite small. There's a very big left ventricle here. And then what happens? Where does the aorta come off? So the aorta there sits almost over both right ventricle and left ventricular outflow tract.
The atria are very big.
The atria are very big. So atria can be very big because they have atrial appendages which can often look massive and just fill with blood after death. So the size of the atrial appendages isn't that relevant. So there looks like septal defect. I can't remember what this one is.
There's no obvious demarcation, is there? Between the
No.
ventricle and the ventricle. No valve.
So I can't see quite where the aorta comes off. Do you remember which case this is in? So I can go back to my notes. And we've got a couple of other.
859.
859. Okay.
Yeah, it says 859.
The one that I don't have. This one. Oh no, here it is. What did we say about this? I think we said this isn't the one. I'm going to try and show it. That's fine. I think this was just a big VSD. Actually, I can't. We had it down. I think I've mixed up one of the 2 other cases. That's fine. Let's bring up the others with, the other 2 with I'll go through those. Is that right? Okay. Anything else? Are you getting a flavour for micro-CT and what it does? You can see there's a few things to I think normal anatomy is normal anatomy. It was just recognising how sometimes a normal anatomy can be affected by other things outside of your control.
Probably an unanswerable question, but how long would you spend going through that stack to do a report on average compared to how long you would take doing a physical full PM autopsy?
I think we're talking about doing a physical PM on a 15, 16 week fetus. I don't know. Maybe 20 minutes, something like that is probably what it would take to report, to go through comprehensively through everything. Maybe slightly quicker if everything looked normal, and slightly longer if there was complex cardiac disease or anything like that. Yeah, and then so probably half an hour, start to finish, by the time you've reported it as all on Epic and it's all available to the pathologist, something like that. How long would it take to do a PM?
Yeah, I mean, you're still going to do some of the elements anyway. So you're still going to do the external. You're still going to do the placental examination.
Yeah,
so
that's true.
For the internal examination, taking the histology and then looking at the histology, you're probably saving about the same amount of time, probably about half an hour, I imagine. So, on average.
Yeah. Can you? This is an uncomfortable question. Can you batch? Because we can batch imaging and just go through them one by one. You can't batch things in the mortuary in quite the same way. That's the wrong word, but yeah. So you have to do. Hey. Well, no, but all the elements of patient respect and handling and not all of those things actually doesn't apply quite so much to images, which you can go through sequentially. So you can do a stack of images of different reports together.
So if you say a lot of them look normal on the CT, in a way for the brief parents, does that still give them closure, even though you have to say, well, the baby looked normal, so we don't know why, or is that when you say we really need to do something else?
So in my mind, the reasons why a miscarriage or stillbirth can happen are very simply either there's something wrong with the baby, there's something wrong with the mother, or there was something wrong with the placenta. So one of the ways in saying there wasn't anything wrong with the baby is by saying all the antenatal imaging was normal and all the post-mortem imaging was normal. If the placenta was then normal, then I think it then pushes the obstetrician or fetal medicine person to look more about the mother and see whether or not there are things like clotting disorders and things that could explain it. So I think it helps as one part of the overall jigsaw. In the same way as if you go, look, the baby looks normal and the placenta has got a massive hemorrhage or there's clearly sepsis, then the chance of that occurring in the next pregnancy, you can now start to give some information about. Yeah. So it's really just about trying to counsel parents in the right way, often usually about what's the recurrence risk. That's a simple understanding from a radiologist. I mean, by all means disagree with me, but I think that's what we're trying to provide to parents, is trying to say, look, what are the chances of this happening in the next pregnancy? Sometimes, I know in the olden days some things took so long, and certainly some of the genetic stuff took so long, that the parents would come to the genetics clinic to find out the results of the first pregnancy pregnant with their next baby. So it's more about trying to work out how to manage the next pregnancy. But in some cases,
we've had experience from getting experience by kids, but where that's been suggested as a reason to investigate was actually really offended the family, because they've been like, how can we even consider another baby
until we know.
And we have just lost one. Why even making us think about subsequent children?
So this one. Says just brought up the T12, so not the whole.
Okay, so this was 12 weeks, termination of pregnancy for hydrops, and they thought it had an abnormal heart but couldn't give a diagnosis on antenatal imaging. So, and there were limb abnormalities. So let's do the heart first.
Can you just put that in context of grams approximate?
70.
Yeah, something like that. That's right.
Okay.
Yeah. Okay, so If we go through the heart step by step, so 2 ventricles, normal anatomy. There's a big VSD there. Can everybody see that? Through the wall of the, yeah, so right ventricle, left ventricle, and there's a gap between them. If we keep going up, so this is the pulmonary trunk here, yeah, which is very small at that point. Oh no, sorry, I was wrong, that's the aorta. This is the pulmonary trunk. And why did I make that mistake? Because it doesn't quite come from, it comes from the back of the right ventricle. Yeah. So the aorta here, which is here, comes from the overlap between those 2 chambers. So that's a VSD with an overriding aorta. So the pulmonary trunk, now looking small, is going to be fallow type effectively. Yeah, and both of the pulmonary arteries here are small, despite pulmonary trunk being reasonably good. So I don't know if I can convince you, but there is, I'll try to show you, the aortic valve here has blood around the different leaflets. Can you see that? The high intensity blood. Okay, the pulmonary valve does not have blood around the leaflets, so that valve is atretic, so even though it's a dilated route. So that's pulmonary atresia with an overriding aorta and a VSD, so that's fallow type. So you can make that diagnosis from micro-CT. Here we knew that I think the heart was abnormal, we didn't know what it was. Okay. If we go all the way down the bottom,
the lungs look less homogeneous than on the previous cases.
Yes. So that's probably just normal variation in how what lungs look like. Yeah. You can see some of the anatomical detail a little bit clearer, but some of the grey contrast is a bit worse. So they clearly have a lower limb abnormality. Or is it just where we cut off the skin?
I can load up that section if you want the whole body.
So I've gone through there. Let's just have a look, because I think. So is there anything else? So the kidneys are normal, the adrenals are normal, the liver's not that macerated. Yeah, stomach is normal. So, so if we go up from here, what's this here? So there's 2 abnormalities here.
Is the bowel sticking out?
Pardon?
The bowel's going out.
So both of those are correct. So the bowels are going out.
Yeah.
Yeah, which is what? Pardon? Examples or gastricitis, depending.
Yeah.
But the baby's not that macerated, so that's not likely to be a macerated or delivery-related issue. Yeah, and then there's a horseshoe kidney. So the kidneys cross over the midline. So now we have a cardiac abnormality, a renal abnormality. We've got gastricitis on the outside. So now we need to look at the vertebrae to see whether or not there's segmental abnormalities. And the best thing to do that with is usually the coronal. So very quick look through there. Looks pretty good. I don't see any segmentation abnormalities there. You can certainly see the horseshoe kidney. Yeah, and why it's called a horseshoe.
Can you distinguish between an example of a gastricitis?
Yeah, what's the difference?
Well, one goes through the ring and the other one comes out through one side of it.
So we can normally see the umbilical vessels.
So then you know it's an example because they go alongside it.
Yeah. So the vessels actually are here within the cord. Yeah, so this is exomphalos. Okay, and then
the whole body of it?
Yeah, the whole body of it. It's fun, isn't it?
Yeah.
It's cool. Looking imaging, making diagnoses. I'm trying to deliberately show you things on the fly, and I'm sorry there's a lag with what I think it shows and then what the images actually do. Oh no, I think it was there.
So much open this one. Okay, that's fine.
I think let's just move our focus onto the limbs. Okay, so if we go up, this is we'll go up slightly too far as always.
If you double click the place for the example.
So there's a normal humerus on the right-hand side. You can see where my cursor is, yeah? So there's a normal humerus that goes down to a normal elbow. And then you have a single bone in the forearm. Can you see that?
Mm-hmm.
Starts off as two, doesn't it? And then one fades out.
Does it?
Yeah.
Yeah, there you go.
Yeah.
Starts off as two and then that one disappears. Yeah. So that's likely to be the radius that disappears and the ulna that carries on. In fact, there are 4 rays in that hand, just that it's curled up a little bit like that. So if we look at this, we should be able to see that. Now, I don't think I could magnify that earlier. No, it doesn't. There must be something like I'll try to do that. Shift. So can you see that? So that is, so you can see obviously an external examination, but we can now identify what the internal structures are of the same thing. So what is that? People call it radial club hand. It's not really a club hand, is because that's related to club feet. But this is a radial ray anomaly. In terms of the radius stops and then there's no thumb development, so you've just got 4 rays, and then the hand is sort of slightly warped. Now the interesting thing is, I think, the other hand is equally affected. You see that? That's really hard to see on external examination, but if we go back up through here to do the same exercise, normal humerus goes down into the elbows. How many bones are there? Again, single bone, and then look, 4 rays in the hand. So bilateral radial ray anomaly. Yeah. So together with a cardiac abnormality, horseshoe kidney, and the exomphalos. So this is either something like VACTERL or associated with it, or another underlying chromosomal or genetic disorder. So, okay, what would you do with that information then if that comes to you?
Genetics.
Yeah, and weight.
Yes.
Genetics and weight. Okay. Yeah. So this is where I think microscopy is really useful. So if there's one abnormality, we often identify others which may or may not have been detected antenatally. The earlier they are, antenatal ultrasound is becoming really, really good, but still we pick up some things that have been missed, or we're able to clarify where they said there was a cardiac defect but weren't sure what it was. This is the opportunity to then give them clarity over that.
I was going to ask about cardiac defects, because often you get your antenatal ultrasound and at post-mortem, even if it's a decent sized heart, you can't demonstrate everything because it's just not the same in life as in death. Do you have a better yield with the scanning?
We've come across quite a few where there are discrepancies, where people think they've seen something antenatally, and in fact, with more detailed imaging and the opportunity to sit down to go through it quite carefully, it becomes apparent it's a different defect. Yes, that's probably the most. Yeah, as do you at autopsy as well. Yes, so it's an opportunity to clarify, but this is non-invasive. That's the only difference. Yeah.
We also know that from PMMRI studies that about 50% of cases of ventriculomegaly no longer have ventriculomegaly.
They disappear.
PM rolls around, so it doesn't mean that the ventriculomegaly wasn't there in the first place. It's just that PM wouldn't be able to demonstrate it, basically.
That's the value, especially for the brain and the heart. It's clear that this really is additional information.
There is also another application, which is that there is, in general, a pressure for women to have medical terminations of pregnancy in order to facilitate a PM. Now, theoretically, if we were able to scan torso and still get, diagnostic quality information from this, you could theoretically apply this to surgical termination of pregnancy and enable what you can essentially manipulate in 3D biology, so you could potentially still get diagnostic yield in the context of some organ systems in this termination. Currently, the US will offer fetal post-mortems in the context of surgical TOP, but that's not done here.
Okay, so one more to show you with lots of abnormalities on it, which we'll hopefully get up. Is this sufficiently entertaining? I don't know. If people want to come and look through these, and scroll through them and look at things in more detail, you're welcome to do that. I think initially when we tried to think about doing this, we would try to do it as a workshop where you'd all have access to things, but I think the computing power slightly stops us from doing that. But there's no reason why you can't go down to mv-VIS and sit on a computer for half an hour and just scroll through a couple of cases and see what you can see. What you can see.
Do it today, come another time.
Yeah. So often when we're going through, so I'll phone Kieran and say, look, the features you sent me with this, I think it has something different. We just need to sit down at some point and go through it. So they're mainly just flags. So there's a discrepancy. So then we arrange a time where we can both sit down in front of the scanner going through it with the antenatal notes, with the external examination, with what we think is probably that, and therefore the implications of what's going to happen when we say, actually, that's not there. I mean, it's different, isn't it? If you see a small VSD where antenatal imaging was normal, that doesn't make a huge amount of difference. If there's been a termination of pregnancy for cleft and there's no cleft, there's been a termination for a cardiac defect and actually it looked pretty normal, those discrepancies, or the curved femur, again, isolated bowed femora, sometimes are really challenging, and even when you take them out and they look normal. So some of those discrepancies, the feedback to the fetal medicine people is quite uncomfortable. But it is what we can see. Okay, so hunt the abnormality time. Okay, anything wrong here?
What is that?
Blood in the brain?
Pardon?
Blood in the brain, the ventricles?
Blood in the brain. Is it blood? So it's bright.
It's bright, isn't it?
It's all within an anatomical structure. It's not in the ventricle. Well, it's in the ventricles, but it's within a structure within the ventricles, which is the choroid plexus. So it just happens to be a big, bulky choroid plexus. So this is normal variation of anatomy, right, is sort of rather than any physiological change. Yeah, reasonable sulcation and gyration. Yeah, Sylvian fissures are developing, so this is going to be 17, 18 weeks or so. There's no corpus callosum yet. Again, this gives you some idea. Maybe there might be a little bit of destruction. One of the things I think that happens during delivery is that the head gets squashed and then there's a rapid expansion. So without normal living tissue rigidity, I think sometimes that causes fractures and things within the central brain structures. So sometimes when you see cracks and things, and that's probably a good example there. Can you see what I'm referring to? That tiny little line there might not be a real fracture through that. Okay, so the brain's okay, the globes are collapsed. Normal brains. Okay, this is the whole body, isn't it?
Yes. Yeah, it's the low res one.
Correct. Low resolution whole body imaging. Okay, we'll have a quick look at the heart here. So this is the aorta, should be, because it goes and crosses there, that's the arch of the aorta, and then that vessel goes down as the descending aorta. Where's the pulmonary trunk? So actually off that aorta come the two left and right pulmonary arteries. Okay, so if we go back down, there's the valve, that's the aortic valve. And if we keep going down, there's a single, so that's a single artery that comes off effectively both ventricles. That's a VSD in between. So there's a right ventricle and a left ventricle, and there's a single artery that comes off that supplies both the pulmonary trunks and then goes and supplies the aorta. So what would you call this? Yeah, truncus arteriosus, or a single conal trunk, isn't it? Yeah. So complex congenital heart disease, but actually quite readily identifiable on complex imaging. And what's nice about the heart is actually that loss of tissue rigidity doesn't usually affect the heart. Heart usually, you can see the ventricles are still nice and up, so even with a bit of maceration, it seems to be one of the last bits that's preserved. So congenital cardiac abnormalities in a macerated fetus are still quite reasonably possible. Okay. So a couple of other things. So can you see this material in the pleural space? Do you know what that is? It's only on one side. There isn't really much here. So there should be no material in the pleural space. There should just be fluid and fluid shifting. So what might that be? There's protein. Pardon?
Blood.
Blood. There's probably blood. Why should there be blood in the pleural space? Yeah, so this is probably a termination of pregnancy. Again, context specific, makes sense that there's a unilateral hemorrhagic pleural effusion, but in the context of complex congenital heart disease and probably a termination of pregnancy. Okay. Let's follow one other thing. Okay, what do we say this was? Do you know what this is in the middle?
Esophagus.
Esophagus goes down into the stomach. Yeah? So follow it up. Comes all the way up. Something funny happens to it there.
Oh, is there a fistula between them?
And that's the fistula between the esophagus, which then ends and becomes the trachea as it goes up. And then that's the normal airway. In fact, there's a little bit of an esophageal pouch there. Yeah? So there's an esophageal pouch that blind ends. Then there's a fistula between the trachea and then the distal esophagus. So I've never seen an actual tracheoesophageal fistula quite as clearly as that before. Even in life, even when you try and find it, you guys have done tube esophograms to try and see these tiny hairline things like that. So that's a really nice example. So now we've got congenital heart disease, esophageal atresia and a tracheoesophageal fistula. Okay, we think this is attributable to termination of pregnancy. Okay, quick look at the limbs, the upper limbs again. So humerus on this side, normal humerus that goes down to the elbow. We'll just see what happens on this side. Two bones that go down, that's fine. These two bones are just following here. And then what does it become? So I think there are 4 rays and a thumb there on that side. Yeah? Happy with that one? Where's this gone?
Might have gone to a thing.
No, I don't know. Just see it.
We could have done that whole body in more detail.
Oh, yeah, that's true. Okay, so just to do the same thing to the other side. So here, the left humerus, as we go down, so the left humerus is intact. Sorry. It's my fault. I'm going off the end.
Yeah.
I look incompetent. This was really bad, but I'm not. I promise I'm not incompetent. This machine makes me look incompetent. That's what it is. So the right humerus goes down into the elbow again, and you've then got a single bone again. See that? Single ulna that goes down into the hand, and the hand has 4 rays again. So this is the classical radial ray anomaly that you get in Foetal with congenital, with esophageal atresia with complex congenital heart disease. Okay. I'll just see if there's anything else to show you. Okay, so we need to check then for vertebral anomalies, and we need to check everything's okay in the abdomen. So as we go up, what are these?
Adrenals. Adrenal glands.
So are they adrenals or are they kidneys?
Oh.
Huh? Because there's nothing underneath them.
Oh.
So they look quite a lot like kidneys, don't they? But they're immediately below the diaphragm. And I don't know, so bilateral adrenal aplasia is almost unheard of, whereas bilateral renal agenesis is quite common, and in the context of all of the other abnormalities, and this is what Lily May had to a certain extent, isn't it? Yeah. So I think these are adrenals. So we just need to see, and there's no kidneys, and in fact just below that, can you see this tiny little thing?
Yeah.
So in fact that's a hypoplastic kidney, and that is a pelvic kidney on the other side. So in fact, this isn't renal aplasia. This is small hyperplastic kidney, and that kidney may not function, but there's a pelvic kidney on the other side. So it's a congenital renal abnormality. But those two things, and can you see how difficult it is to see? It's easy to go past that and go, oh yeah, that's fine, 2 kidneys, normal place. Yeah? Okay. So yes, so that's a kidney. It's a pelvic kidney. Okay.
The scans would probably be quite good at picking up prostate urethral valves, etc.
No, you never see the valve. So you'll see urinary obstruction, you'll see bladder outlet obstruction, you'll see a big dilated bladder, you'll see the uropathy that you, yeah, so you'll see big dilated ureters and you'll see the renal cysts and things like that. You never see the valves. And even when we've taken out bladders and the prostate and then micro-CT, just those bit, you still don't see the valves. It's one of these things we've looked at with our urologists repeatedly. So the valve within a tiny sort of urethra is almost beyond what we can visualize. It's a real shame. It'd be really nice if we could demonstrate those things. So you see the uropathy. You see it's pretty obvious. It's a boy with a big trabeculated bladder and dilated tracts. It's fine. So the diagnosis is not challenging, but demonstrating the valve is really hard. I think that's all of the normals, the macerated ones, the abnormal cases that I've come to show you, to give you a spectrum of what you can see, the sorts of things you can do, the 3D images you can do. And so this is effectively routine. This is day-to-day collection of what we would do. You've heard all about how it's done, how we prepare everything, how we reconstruct them, how we report them and send information back to pathologists, and how we approach parents and the charity sectors about whether it's something they should get involved in. So you've probably had today a run-through, the most comprehensive run-through of how to do micro-CT than anybody's ever had before. So hopefully we've inspired some of you to do it, to adopt it, to start to... I think you've got such a good setup here in Southampton with so many interested parties and so many supporters of what you could do, and quite clever engineers and technologists that could really support this program. So I hope it gets off the ground now.
For anybody that missed any of it, it all has been recorded, and we can make either the PDFs or recordings available later. It was a long day. I would like to invite anybody who'd like to come downstairs and see the scanners. If you're interested in seeing where it would happen, we can go down and have a look. I don't think you've seen our
I've not seen it. Did
scanner.
You guys just go down, or did you go to the
They've
mortuary?
been to the
Ah, you went to the mortuary. Okay, let's not go there. Yeah, let's go see your funky scanners.
We can go see the scanner. If you would facilitate a tour for us downstairs, that would be really good. If we could, I know that's a surprise.
Yeah.
We could just lock the door, leave all this up here for the moment, and come down. But now is your chance if there are any other questions or things we want to talk about.
Because you've got mortuary people, you've got technicians, you've got obstetricians, radiologists,
families,
pathologists, family liaison. You have lots of people in the room together, haven't you? Any questions? Yeah.
What's the size of an average scan data set, and what's your data retention policy? Do you retain your raw scans for 30 years in theory, or are you making a diagnostic snapshot?
At the moment we say that.
Yeah.
Is that sustainable for the future then?
Yes.
It is really.
We're going to have to keep.
Sorry.
Even all your raw projections.
Yeah.
What's the average size then per patient?
About 30.
Yeah. So that's for 3 separate scans, so whole body and then 2 high resolution scans. So that's overkill, isn't it?
Yeah.
Storing all of that data for everybody is overkill.
Yeah.
So we've probably done near on 1,000 scans, I think now. So it's a lot of I think it's one of the ways that you have to think about how you're going to store all of this in perpetuity. It's possible that somebody could get to 18 and then say, I want to see my scans later. Not post-mortem, but it's possible. I'm trying to think of the repercussions. So we have made diagnoses from post-mortem imaging on living children. So because they're affected with the same thing and they didn't know what the diagnosis was in the child who survived, and then you get somebody who's more severely affected with the phenotype, you make a diagnosis and you realise that the 5 or 10-year-old is also affected. So
Can I ask a practical question? Do you have a template referral? Because obviously you're talking about there's quite a lot of crucial information that helps you.
So this is Vanya, the form that everybody has to fill in if you want to refer, isn't it?
Yeah, I think
template referring.
Yeah, I imagine Southampton will have something very similar already set up for the pathologists, where we get a London perinatal network form, which prompts the clinicians to fill in relevant antenatal history, what the background of the case is, and risk factors, and whether there's any particular points that enhancement.
So the most useful things are pretty obvious. So body weight, estimated gestation, mode of delivery, and then any antenatal imaging. Probably the 4 key things that you need to be able to interpret this camera.
And do you get the antenatal imaging transferred to? Not
the imaging. We sometimes get the reports, because we usually get a pack, don't we, with most of that is copied in there. And it's usually just a report of, was it normal or was it abnormal? Yeah.
Even for the ones who come in from your 13 or 14?
Yes. Yeah.
If we don't get that, if we're doing a babygram down here, I wouldn't normally have access to any information.
Normally when we're reporting the babygrams we don't either, but there's usually stored in the mortuary somewhere, and I think some of that has now been started to be scanned on Epic, and it should be a standard.
Yeah, we scan them all into our drive.
It's pretty reasonable to say to your referring centres that we can't do anything if you don't give us this information, so it's almost a minimum data requirement. Yeah. The antenatal imaging is really key, but if you haven't got it and we think there's an abnormality, you just go back to the referring centre and say, look, you need to dig this out and send this to us. Yeah.
I asked that none of our pathologists would go back to not having micro-CT. Everyone thinks it's a good thing.
Yeah. And CT for the forensic cases, and there's a lot of things where now we do imaging as routine, and it's become expected now as routine. And you're right, to now withdraw it would be challenging.
And when I recently met up with the CEO of this Code Association, the fact that we were coming to this and talking to you guys and had such a collaboration with BIU and such like, that was what got her really excited, because for the past 2 years she's been in her head, how does this get upscaled? How do we move this out?
How do we
the
get
fact
another
that this is happening today was really, really impressive. And when we talk to parents, that's the first thing that they say, that's proof it's going out. It's moving on to other centres. It's the real key thing, because it can't just be great orchestra for the whole but the fact that it's moving out.
And we have the equipment's here already. We don't have to buy it. We don't have to ask for money to buy it.
There's 4 big micro-CT centres, isn't there, as part of your network? UCL, and gosh, Southampton, Warwick, and then Manchester. So we know Tim in Manchester very well. He's going to start doing some forensic micro-CT for Chas Mangum, because they're in Stockport very easily. Mark in Warwick is already doing some forensic stuff. I'm not sure they're staffed to do fetal stuff, but maybe again you've got the technology, so wouldn't it be nice if you guys were a little bit ahead of the curve?
Yeah.
I think that's the key thing, though, isn't it? We've got the lovely technology
Yes, that's it. So if we have to put a business plan together, it's for staff.
There's not much missing though from your whole jigsaw. There's not many missing pieces.
Yeah, and that's what we need to ask for. But it should be to our advantage that we're not asking for £500,000 for equipment. That should really be behind us.
It's the £500,000, and it's also where are we going to put this thing?
It's usually one of those.
Actually, it's already in the hospital. It's already working. It's already working.
It's in a room opposite a mortuary.
The fact it's in your hospital is going to be really advantageous.
I think we need to take the things we have to our advantage, find out, do the gap analysis to find out what else we need. And I think after today, we know that it's more staff, more people like you, and more.
So from a staffing perspective, because we're already staffed and funded to do the babygrams, there is actually, and I was talking to Orestes in the break actually about training some of our paediatric doctors who already do the babygrams to actually do that, because actually if we're not doing the babygrams, we've already got the stuff.
Yeah, it's a bit of borrowing from
that's even less of a sort of funding. Yes, it takes a bit longer, but actually we have the stuff already.
Radiographers, I speak to lots of radiographers when I go to conferences. I'm really excited about it.
How can I get to do this?
They come up to me, this is amazing. But actually, radiographers would be really interested in it. We'd be more than happy to chat to them. They can come and visit me at the centre and see how the practicality of doing the whole of this.
We've already got someone on the masters who are doing the masters in forensic imaging. So I know it's not quite forensic, but there is
it's the post-mortem is the overlap. So what we've tried to do today is to showcase the things that you can do and how the system that we've set up over many years now to get it up and running, to be working. We obviously you've got open access and free to come if you want to see now hands on how we do things. Come to Gosh, whether that's somebody from the mortuary, somebody, radiographer who wants to spend a day, radiologists who want to come and look through the data archive, or fetal medicine pathologists who want to just see what the workflow is. Just come for a day or half a day or whatever, just to spend with us and pick up all the good bits, pick up all the bad bits. Say yeah, we should do that. I'm not doing that in Southampton. Get what you need to out of it to make it work.
Because it already exists. You've already done the work. You've already developed the protocols, and we should be able to just pick them up and bring them here. Yeah. And that should make it more acceptable to the trust as well, that it's an existing and tested service that works somewhere else. Yeah. We're not doing research. We're not inventing anything new.
We need to sort the pathways out.
Yeah.
Yeah.
And the training for informed consent and getting that across.
Yeah.
Interest is there.
Great.
Yeah.
Yeah.
Just that joined up thinking.
That's it. Yeah.
But again, you had the bereavement midwives here today. They're quite keen, and they would be able to explain it. The communication with parents is really important.
So I think after today, what Orestes and I would like to do is have another meeting with representatives of each group rather than every single person coming back again, and we will do that gap analysis. We'll see what's missing. Orestes has already started a business plan, but now we maybe understand more about what we need to put into that and what we need to ask for, and then start asking for it, I think, and start. Yes, Beth.
I'm just going to if there's anything still missing from your clinical service that you haven't been doing. You have not been through an inspection process yet before your clinical service. Is there anything else that you're still working through?
We have been through an inspection service. It's just the UCAS sort of said, well, is this part of your provision of post-mortem? And we said, yes, it's part of our it's part of making an examination. We said, no, okay.
That was it. That was the inspection. So the thing about obviously UCAS is you can opt to keep something unaccredited, or you can put it into your scope if you choose to. But with HTA, you might have.
So we're accredited. We're a UCAS accredited mortuary, but we're accredited for making an examination. That is how we choose to make an examination. So
it's pretty loose.
Yes.
And then the HTA, a big inspected.
We're due an HTA inspection now.
And there's a further question: do we need any risk codes on Epic for doing this kind of thing? It was just a CT, isn't it? Whether it's a normal CT or a micro CT, it's just a CT. So CT post-mortem, that's fine. All those codes and things exist. So just use the existing things that you've got to fit into your, the pathways.
Sorry, but my hat on now. So do you, if you do because I know you talked about some you do babygrams and you do post-mortem CTs.
Yep.
So you just put the XSSPM and the CTPM code, which I can't remember what the head is.
Yeah, it's CTPM.
Code those, and your commissioners pay for both.
That's another thing. We haven't talked about money all day. It seems rude to talk about money in a situation.
We could spend a whole another day talking about money.
Yeah, but it's we can sell that to the trust as well as an income stream that will bring in.
Oh, the commissioners are not paying. Commissioners don't.
No.
Yeah, well, even
commissioning perinatal pathology service is going to go under a massive review in the next 5 years. So they're going to look for centres that because we don't have enough pathologists. So they're going to look for centres that offer similar or alternative services, and they're going to be willing to pay for them because they're being pushed by parents and charities like yours that we need to do something, and we don't have enough pathologists. So the middle ground is going to become very appealing and financially beneficial. That was politically correct, isn't it? Pardon?
What would be the middle ground?
Well, so from no autopsy to having an autopsy by a perinatal pathologist. So imaging is going to be a feature in that triaging who needs to be done further, who doesn't. So yeah, that will become a commission service. No, but like going to A&E and having your fracture, whatever, imaged. So you're using it as a triage service to decide who has more abnormalities and would benefit from an autopsy, and who doesn't, who's normal and fits with the antenatal history.
Yeah. I think it would streamline our services as well, isn't it? So that we're actually spending our limited resources doing something that adds value. Stuff. That's why for limited clinical information.
Yeah, there are so few of you. You might as well be doing the important stuff as not. Yeah.
Although negative results are also very important to find.
Yeah.
Where there is nothing, that's
yeah, it's just much harder to quantify. So how useful a normal result is really difficult to quantify, except from the parental bereavement perspective, which again is difficult to evaluate, and that the impact of what parents did or didn't have is very difficult, I think, to say, oh, it was that really helped or it wasn't. I mean, there's lots of anecdotal evidence out there. It's very difficult to do those studies of large groups of parents who've all gone through something slightly different as to what it was that really helped or really didn't help.
More or less of the same than a normal micro-CT.
Yeah.
Well, I think if you can find that it's normal, that's fine. The easiest and most efficient way to do that is the best.
Yeah.
And ultimately, I think that will be more cost effective because pathologist time and all the rest of it is everybody else is doing other things as well.
So it's probably not dissimilar to the way AI is going to probably work in a lot of these things. So lots of people trying to use AI to pick out abnormalities and see how good they are at detecting things, things on a chest X-ray, or and they turn out to be not very good at actually telling you what's wrong. But they tend to have very high negative predictive rates. So when it says it's normal, it's usually really, really good at that. So even if that's only 10% of the time, actually that's 10% of your workload that's now gone. So the stuff that it says, well, I don't know what that is, but I think it's abnormal, you can spend time doing that rather than the bit that it said, and the trust will accept somebody not looking at those things because it's a more efficient way. So we could use imaging in the same way. Look, this is a miscarriage fairly early on, normal antenatal history, normal scans, the micro-CT is normal, it's fine. So we don't need to worry about those for autopsy. Let's focus on those where there are abnormalities and things. So I think it'll become used a lot more like that. The negative predictive value is pretty high. All right. Good.
Thank you very much.
Pleasure.
Thank you to everybody who's come down, and we can give another round of applause. Thank you.
Team effort.
We very much appreciate your time and expertise. It's been great. I think it's not the last you will hear of us. We'll be back asking more questions because after thinking for a few days, we'll think of the other questions we didn't think of today. So we'll be back.
Come look around as individuals or as teams or as whichever bits that you feel you need to do.
Yeah. Thank you. Thank you to the online people for joining us too, if they're still there.
Thank you so much.
We had about 15 or 16 people online earlier, so it was a really good group of people who joined, so it was pretty good, yeah.
Should we take a break and then can we go down to
to your
facility?
We absolutely can. Just to